Thank you, Edgar. I'm referring to Edgar Para, who is also a co-worker from the Oregon Health Authority Medicaid program. We also have Molly Taylor, who is helping with tracking the comments and any hand raising, as well as Spencer Delbridge, who is here and will be keeping track of some notes or themes from today's conversation. So I thank them for that assistance. Let's go ahead to the next slide. Okay, we've already done some introductions and appreciate if you had joined and missed that first slide. I did ask everyone to put into the chat their name, their pronouns if they wish, as well as what organization they're connected with, or if you're just a general member of the public. You don't have to be part of an organization. In fact, we really hope to lift up voices for those who have been on Oregon Health Plan, are currently covered by Oregon Health Plan services, or they are an advocate or family member of someone receiving Oregon Health Plan benefits. We do have quite a few folks here, and I'm really happy about that. We had a session yesterday. This is not a continuation of yesterday. It is a total new group, although people may choose to listen in to both sessions. And we have people who are here requesting to be a Rules Advisory Committee or RAC member, and many others who are here just to listen and observe and learn. So I'm going to ask Spencer Delbridge to do a little roll call of just those individuals who identified in the registration that they wanted to be a seated RAC member. So I'll pass the microphone to Spencer.
Thanks so much, Diane. Welcome, everyone. What we'll do with this roll call for RAC members is I'll read out the names and just ask you to come off mute and let us know whether or not you're here. And we'll start with Tamara Bakewell. Okay, we will move on to Hazel Clements. Again, please just unmute if you hear your name called and you wish to be identified as a RAC member. Okay, Chris Bonev. Dr. Rosemary Hemmings.
Here.
Thank you, Dr. Hemmings. Jessica Jacobson.
Here.
Thank you, Jessica. Angie Martini. Gary Cobb. Dana Steringer. Maggie Klein. And before we close out this roll call, is there anyone who signed up that registered who wishes to be a RAC member but did not hear their name called?
Hi, Spencer. This is Adam Peterson from HealthShare. I registered as a RAC member yesterday, but due to a sick child, wasn't able to participate. So if possible, I'd like to be considered a RAC member today.
Thanks so much, Adam. Good to see you.
Thank you, everyone. Again, so just a quick review of what we hope to cover today. It is a full agenda, so appreciate your stamina. We'll take a couple of breathing moments. Hope you have your coffee or tea or water, whatever you need to take care of yourself. We will cover the RAC participant fact sheet just briefly. I sent this out also along with the 3 administrative rules that we will be reviewing today to everyone who registered. So that should have come to your email. We will look at those rules one by one and just recognize that Oregon administrative rules have the effect of law. Rules are written so that they put into place the guidance and the regulations and laws from both state and federal laws. And these provide the framework for how the Oregon Health Authority operates the state Medicaid program, which is called the Oregon Health Plan. You might also see us use OHP, abbreviation there. The purpose of a Rules Advisory Committee meeting is really to review proposed language for administrative rules and invite input from communities that are affected by administrative rules. Communities could include persons covered by the Oregon Health Plan, community partners, providers, contractors. So there's a broad audience that we're really hoping to lift up your voices. We recognize that, excuse me, the Oregon Health Authority has not always done a very good job of really elevating the voices of those groups. So we are working to do a better job with that by making our meetings more accessible. We are physically offering this at the Salem Public Library, as well as virtually, and offering language support services. We also have expanded the times of the day that we're offering these meetings in order to reach a broader audience. So appreciate you attending today. Next slide. I will be sending out this slide deck to everyone who registered for these Rules Advisory Committee meetings after our session, probably later today or tomorrow, along with a short survey to get your feedback on your experience with today's session. So look for that in your email. Again, what we'll be covering are those 3 rules that are brand new rules for Division 120 that speak to really the framework for establishing care coordination standards. We'll talk about the potential racial equity impact of these rules, as well as consider if there are fiscal or financial cost or savings or cost incurrences for how we operate these rules. And then lastly, we'll talk about the next steps in the rulemaking process. I'm going to pause for a moment and see if there are any key questions that have popped up in the chat. Molly, anything I should take a look at?
Kind of the main question is, how and will folks know about continued rec meetings? I think folks are excited to be here, but wanting to make sure that they're on a listserv, or kind of asking how to know about future meetings.
Thank you, Molly, and appreciate that question being raised. So my hope is that we will be able to cover these 3 rules during today's session. If we don't get through everything in the 2 hours that we have, then we may need to schedule a second meeting. So we'll talk about that as we get close to the end of our time together. If we get through this first draft version of the rules today, again, there will be an opportunity for RAC members to provide additional written comments. I know sometimes when you're sitting here and you're looking at these rules, or you're hearing comments from other people in the room, that may spark something for you, but you need a little time to frame up recommended language. So there'll be an opportunity for you to submit comments to me by 5 p.m. on July 5th. And then, of course, that's not the last opportunity, because even once we file proposed rules, there is a public comment period where anyone can offer feedback. So thank you. All right, let's move to the next slide. I wanted to start with grounding our conversation by looking at the Oregon Health Authority vision and health equity definition. And this slide I will read because there's a lot of words, and it's really important to ground our work. The vision for the Oregon Health Authority is really one that is a healthy Oregon where people and communities achieve optimum physical, mental, and social well-being. So that really centers a whole person. So thinking about your physical health, your mental health, your social well-being, the communities where you live, work, and play. The health equity definition that OHA has adopted is one that reads, Oregon will have established a health system that creates health equity when all people can reach their full health potential and well-being and are not disadvantaged by their race, ethnicity, language, disability, age, gender, gender identity, sexual orientation, social class, intersections among these communities or identities, or other socially determined circumstances. Achieving health equity requires the ongoing collaboration of all regions and sectors of the state, including tribal governments, to address the equitable distribution or redistribution of resources and power, and recognizing, reconciling, and rectifying historical and contemporary injustices. So that's a lot to sit with. But I wanted to share that so that the people in this room today know that the Oregon Health Authority is committed to changing the way that we do our work in order to move towards this vision and support our health equity definition. Okay, let's move to the next slide. And just a little few comments about care coordination and rulemaking, what we're here to talk about today, and why this matters. We know that care coordination is one way that we really can help our Oregon Health Plan members achieve that whole person care, that striving towards being fully healthy or as healthy as an individual can be. By having documentation that is established in rule, it allows the health authority to set a standard to make sure that individuals are receiving the right care at the right time and place by the right providers or people, and that everyone is communicating and working together with the member, the Oregon Health Plan member, and their family. Having good care coordination is shown to be the best way to support that whole person wellness. Just a definition of care coordination is really the deliberate organizing of healthcare services and sharing information between doctors and healthcare team and you as the patient and your family. So really centering the individual is at the core. Okay, next slide. Okay, take a breath wherever you are before we dive into the documents. I couldn't find a picture of someone who might be sitting in a park or at the beach, but wherever you are, take a deep breath, stretch, take a drink of water, which I think I will do. Okay, next slide, Edgar. Currently, within the Secretary of State's Oregon administrative rules, there are a number of chapters that relate to different agencies and governing bodies. Chapter 410 is the chapter that relates to the medical assistance programs or the Oregon Health Plan, Oregon Health Authority. In that chapter, there are different divisions. Some of the divisions are specific to certain programs, such as school-based health services, health centers, vision services, etc. Division 120 has the general Oregon administrative rules, and we do not currently have any general rules that describe care coordination. So these are brand new rules that would be overarching rules and specifically apply to the Oregon Health Plan members who are not enrolled in CCOs or coordinated care organization. Lots of common terms. You don't need to memorize this. I just want to set the context. Our guiding principles really for this work are to make sure that the standards for those individuals who are on what we call open card or fee for service, that those individuals are receiving the same level of care coordination that is available to individuals that are enrolled with a CCO. So we want to align these new rules as closely as possible with the care coordination rules that are in Division 141. The drafts of these rules, again, align with those 141 division rules, and they also reflect input that we received during listening sessions that we convened in April, just a couple months ago. Some of the themes that came out of those listening sessions were that individuals felt it was really important that they understood who their doctor or their care team was and how to reach them, that they knew how to receive information in a language that they understood, and that care coordination really considered the needs of the individual. We heard examples of challenges with transportation and the importance of considering where referrals to other services were, so that, for example, an individual wasn't traveling from the edge of one county to another county or the opposite side to see different specialists. Those are things that create barriers for our members who often have very complex healthcare needs, where that coordination of care is critical to a positive health outcome. Okay, next slide. So on this slide, there are links to the RAC participant fact sheet, as well as the different rules. Let's take a quick look at the fact sheet. There's an English and a Spanish version, so thank you, Edgar, pulling that up. Okay. So scroll, yep. So again, you would have received this in your email after you registered. And again, the Rules Advisory Committee's purpose is advisory, as the word says, that consensus is not necessary. Again, we're really seeking to listen to and lift up voices of the public and our partners to gather input about new language or modified language in the draft rules. go ahead and scroll down. As we open up the rules in a minute, we'll be asking our Rules Advisory Committee members to offer comments. I would ask that if you come off mute and you speak, if you could introduce your name and your organization, and that way everyone who's here today knows where your comment is coming from. You can also, of course, put your comments in the chat. We will be capturing all of the comments today. And as I mentioned, RAC members are able to send me directly at my email additional comments. Again, I know that it's hard to think of everything in one meeting. So accepting those comments until 5 p.m. On July 5th. And then as you scroll down on this page, it describes sort of the next steps and activities with target dates. These really are just target dates, subject to change, depending on how much input we get from these meetings, as well as the public comment period and public hearing. So more to come on that. All right, let's go back to the slide. And let's get into the real work with the first rule. This first rule has to do with really the framework or the infrastructure, what needs to be built in the care coordination. So this rule is 4 pages long, and in the interest of time, I am not going to read all of the rule. We'll go sort of a few sections at a time. Again, these are brand new rules, so it's all new language since we did not have, there currently isn't a rule that is labeled 410, 120, 1215. So looking at this infrastructure, I would ask that our RAC members take a look at page 1. And if you look at, it covers sections 1 through 5. And I will open it up. Again, RAC members, feel free to add, come off mute, raise your hand, share with the group any comments or questions, suggested language. Okay, I'm not seeing any specific comments in 1 through 5. Again, this focuses on what are systems that are needed to be in place to support care coordination, to focus on the needs of individuals, okay, let's move to page 2 of this rule. And again, invite Rules Advisory Committee members to take a look at sections 6 through 8. Again, these sections talk about the importance of taking a look at the coordination between programs and really sort of the principles around care coordination. So again, the goal is that, as it states here in number 7, section 7, care coordination should improve health outcomes, ensure an individual's ability to live well, increase an individual's satisfaction with their care. There's the goal of reducing health inequities. Okay, I'll pause. Molly, anything in the chat that I might have missed?
Nothing in the chat so far.
Okay, Rosemary Hemmings, please.
Hi, good morning. Dr. Rosemary Hemmings from Black Therapists and Company. My question is, the term care coordination, I appreciate the definition, but when I see the lead-in care coordination entity, how is that determined and who decides on who is the lead-in care coordination entity? Is there a specific, are you specifically referring to any specific entity? I'm thinking of CCOs, but how would one know who's the lead in this situation?
Thank you, Dr. Hemmings. Yes, I believe that is addressed perhaps in the next rule. I've looked at these so many times. Excellent question, and we will keep that in mind as we look forward, and if it's not covered in another rule, I think Bonnie mentions that it's addressed in the element above in this rule. So.
Yeah, I think that's important because oftentimes when you have individuals who's involved in multiple different agencies receiving services from many different sources, it's often hard to figure out who takes the lead. I see the responsibility for, what the responsibilities for that lead entity, but I think it's also important to have a way of deciphering which is the lead agency entity in patient's care.
Yeah, excellent point. And there is some language, yes, in this rule. It's on page 1, section 4. So, Dr. Hemmings, perhaps maybe separately from this meeting, if you want to take a look at that section, and if there are some additional language edits that would make that more clear.
I was asking, thank you. I was wondering if this was referring to CCOs. Okay, great. Thank you.
Yes. Thank you for the question. Okay, let's go ahead and move to, again, at the bottom of page 2, is the start of section 9, which is a lengthy section. It continues all of page 3 of the rules. So let's go ahead. Yes, thank you. Thank you for helping me monitor. Jessica, please.
Hi, good morning. Jessica Jacobson, Sheever, and manager for care coordination with Multnomah County's Behavioral Health Division. I have a question. I'm not sure which spot to specifically direct it to, but I guess it's actually going back a little bit to, oh goodness, where did it go? I think it's like the section 3 and then again like section 6. There's a number of system entities that are identified here that are not necessarily healthcare entities. But it seems to be saying that there's a definite responsibility within care coordination to collaborate across these multiple system partners. And I'm curious if this addresses any like information sharing rules, I guess, essentially. Like, does this rule give permission for OYA to be sharing information or for a healthcare provider to be sharing information with them? Does that make sense? Because I feel like some of these system partners typically would require specific releases of information in order to cross-coordinate.
Yes, Jessica, thank you for bringing that question forward. This rule does acknowledge that collaboration and coordination among agencies and different entities. And another related rule is where it speaks to sort of those additional systems, sort of the IT systems or the memorandums of understanding agreements. So we certainly recognize the need to protect personal protected health information. So those apply, and it's referenced, I believe, in the last rule, the 1225. But there certainly are broader requirements around HIPAA compliance and that information sharing. So appreciate you calling that out. Okay, well, let's go ahead and move forward to section 9 at the bottom of page 2. And again, invite, and it continues all through page 3, I believe. So welcome any specific comments or questions about section 9 that addresses, again, some of that infrastructure that's required, and making sure that individuals are aware of the availability of care coordination services. Yes, Chris. Good morning.
Good morning. Thank you. And I'm presuming I'm on, I'm part of so many racks right now. I'm hoping I'm not speaking out of turn that I am on this rack. Indeed. I think it's a little bit problematic that there's going to be such a high variety of potentially scoring mechanisms and that they're going to be judged on an individual basis. And that doesn't seem consistent with the goal, which is consistent care, making sure that we're meeting people's needs, in particular, making sure we're meeting medically necessary services, whether those be medical, surgical, or behavioral health. NAMI would like to see the health authority sort of, if not one tool, maybe a suite of tools that it references and permits in advance, saying CCOs, hey, here's what we think you ought to be using. And that variances be allowed, but that be sort of an exception that is rarely exercised versus the consistent use of tools that do assess risk stratification.
Thank you, Chris. Appreciate that. And I think we would support that a concept. I can't speak to what the Division 141 rules will land with in terms of that risk stratification sort of model, but I believe they are working with CCOs on developing that with the idea of standardization. And again, because the goal is that all Oregon Health Plan members, regardless of how they're being covered, whether it's through the CCO care delivery model or through open card fee for service, that there is consistency for what we expect that experience to look like. So appreciate that. And we
Yeah,
are.
if I may just
Yes.
sort of tag on to that, I think it's, what we want to avoid is somebody scoring one way within one region and scoring vastly different in another region. And I think it's also here that if you are going to deploy these things, that some training be required, inter-rater reliability, something that evaluates whether or not, one, these are effective, and two, if they're being applied as intended.
Yeah, excellent. Sort of that, quality assurance piece so that there are some checks and balances. Thank you. And while I am working on these Division 120 rules, just want to express that we are working very closely with colleagues who are working on the Division 141 rules so that, again, we're in alignment as much as possible. Okay. I think Section 9 is the last section of this rule. So I'm going to, and I'm looking at my watch, so I want to keep us moving forward. I will have Edgar pull up the next rule. And while Edgar is doing that, invite you all to take a breath, stretch. Take a drink of water. Okay. Thank you, Edgar. So we will transition to the second of the three rules, which goes into more detail about how individuals with Oregon Health Plan coverage, how their care coordination needs are identified. In other words, how do we know which individuals could significantly benefit from care coordination? These are often individuals that may have complex or multiple health conditions where really urgent health care needs. And so wanting to support those individuals when those needs arise, whether those are physical health, developmental health, behavioral health, oral health, social needs. You'll see the term health-related social needs and social determinants of health and equity. So again, consider the whole person. What are their healthcare needs? So I'll invite RAC members to take a look at page 1 of this rule in sections 1 through 2. It describes how those individuals could be identified. As Chris and others mentioned, thinking about a risk assessment, perhaps a standardized tool, and how that is implemented to help identify who are the individuals that could benefit from care coordination. Rosemary, Dr. Hemmings.
Hi, Dr. Hemmings, she, her, forgot to say that. So I have a question about if vagueness, I think, was what leads us into trouble. And I'm looking at individual's health condition requires. Based on whose determination? Says HRA within 90 days. I'm not sure if there's a standardized health risk assessment. Full disclosure, I used to do this when I used to be at Care Oregon. But I'm looking at, or sooner, if individual's health condition requires. How we defining or determining what health condition would require this? Is this just left up to the individual CCO? Yeah.
Yeah, appreciate that call out, Dr. Hemmings. And if you have any suggested rewording of that, happy to take that into consideration. And I think there could be some additional guidance documents that would support.
I'm thinking about multiple comorbidities, which is pretty much standard, I think, within the healthcare sector, might be something to consider. But that's just one, because I don't want it to seem as if someone has to have multiple comorbidities in order to determine that their health condition requires a health risk assessment sooner than 90 days. But I think that could be one criteria as well.
Yeah, great. Appreciate that. Molly.
Oh, it looks like my comment, or I was gonna just read some of the comments, but it looks like Bonnie from Quality is answering some specific questions. So I am gonna go ahead and mute again.
Thank you, Molly, and thank you, Bonnie, from our quality assurance team within our coordinated care organization unit. So again, direct folks to take a look at the comments and the answers to see if there's additional guidance there. And they are working on risk stratification processes for CCOs currently. Perfect. Thank you, Chris, for your comment too. Okay, well, let's move on in that rule to section 3, which starts at the bottom of page 1 and continues on all of page 2. Section 3 describes some of the sources of information that could inform the health risk assessment and It speaks to some consideration about new medical diagnoses, courses of treatments, and emergent needs, or new social determinants of health needs. So open it up for RAC members. Dr. Hemmings?
Yes. You know, what in terms of social needs, you know, I'm just thinking about how does a CCO become aware of the social needs of their members, right? At what point in the membership, because they refer to them as members, would a CCO become aware? Do they have ways of identifying members who may have more social needs than others? I do remember you saying that there is going to be a requirement that the care coordination entities have a way of identifying members who need care coordination. And I'm hoping, and I'm asking, I guess, is there going to be a requirement embedded within this process or this rule that includes identifying the social needs of their members at the point of enrollment? So in thinking about social determinants of health and health-related social needs, at what point is that actually implemented in the membership process, right? If we're doing a questionnaire, I'm not sure what tool they're going to be using to make this determination. Because those social needs are not always something that is easily identifiable, because you can't really go and look at someone's previous admissions or utilization of, the healthcare system. You may see diagnosis, but that won't necessarily give you what you need to determine, social needs of that member. So I'm just trying to think about how that will be determined, because I often see that, clients that I see, that is not something that is being addressed, or that the CCOs are even aware of, or the member themselves doesn't even know that there is opportunities there to get those needs met through the CCOs.
Yeah, appreciate that. We'll capture that and see if that's part of what's being developed in terms of any resources to standardize how that information is collected. I want to invite Adam to come off mute. Thank you.
Hi, thanks Diane. Adam Peterson, he, him from HealthShare, and I provided the same feedback in the CCO rack, but I think it holds true for looking at fee-for-service. Many of these, rising risk factors that are listed are things that CCOs, or I would assume fee-for-service organizations, do not actually have access to readily or in a timely fashion enough to be considered rising risk, such as a mobile crisis response is likely to be captured in claims, which then means that by the time you are receiving notification of a mobile crisis claim, it's going to be months after that mobile crisis timing. And therefore it creates really a hard or a challenge in determining how best to use that information once it's received, because that incident is likely past of its when its usefulness of care coordination would be. And then newly diagnosed change or chronic disease diagnosis, there are many chronic diseases that are managed well at a primary care level and wouldn't necessarily need to have a health plan or a coordinated or a fee-for-service care plan created for managing what should be manageable at a primary care level. And so when you're looking at things like chronic disease, not every chronic disease requires care planning at a high level. And so my suggestion would be to find a different way to determine chronic disease and more defined to make it less less broad in how that's defined. And then there's a newly diagnosed or a change to an intellectual developmental disability diagnosis. Many times there's a strong a separation between intellectual developmental disabilities in a community and then the service provider who would be creating a care plan. And this would require, I know that it's called out in a previous rule, but needing to have connections to your local organizations that you'd be coordinating with. However, this is one that just in common practice is not, these organizations do not currently care coordinate together as far as my awareness is, and therefore it feels like an unrealistic expectation to include anything like it would feel like needing to seek out information that isn't readily available, and there isn't information sharing between agencies currently that would allow for that. So those are the ones that I think make it hard to include in rising risk. Thank you.
Thank you for that information, Adam. Appreciate it. Molly.
Yeah, there's a comment in the chat and I just wanted to read it out loud. It's from Chris asking, is C inclusive of behavioral health? Often behavioral health is called out separately to ensure it's included. I noted it's called out separately in G, but that only covers changes in circumstances. So I just wanted to share that.
Thank you, Chris. We'll take a look at that. Because certainly behavioral health needs are part of that whole person care. So appreciate that. All right, I'm going to move us along. Okay, we are.
I'm sorry, Diana, do you realize
Yes.
Chris Bonifkin? I realized I didn't introduce myself. Also, I'm with the National Alliance of Mental Illness, NAMI Oregon. Just a quick sort of bouncing off the previous comments. I think one of the difficulties that we encounter in Oregon is where does care coordination actually rest? And so in those circumstances where it's not at the health plan level and it may be in fee for service, this is somehow attached in a different way. In an ideal world, somebody say with ongoing needs, if they do have a mobile crisis response or they are having newly diagnosed, there's something that gets pinged. And so I would use, say, our CCBHCs, community, behavioral health homes. In an ideal world, our primary care medical homes would also be pinged, right? I mean, there are these ways by which information can flow. It just doesn't always go, say, to the plan level in terms of hitting something until someone looks at the claims data. I only point that out is that if you look at this section and there are things that really aren't plan level, and again, this is fee for service, so it's different, but that rather than maybe require it, but still include it as something that you want to look at or be aware of. Does that, hopefully that comment makes sense.
Appreciate that, Chris. Yes. I think that challenge is really building some of those structures so that some of those, as you call it, pings, those things that trigger an alert to take a look at. And I think we're certainly in, I feel like building the framework. We're building a brand new house and we've maybe poured concrete and we're trying to frame it up. So appreciate the feedback. All right, let's move on to The last page in this rule is sections 4 and 5, which talk about some of those populations with specific needs, such as those individuals who have special healthcare needs. You'll see it there in 4A, abbreviated SHCN, as well as individuals who may be receiving Medicaid-funded long-term services and supports, and how those are often connected with federal requirements. Any feedback from RAC members on sections 4 and 5? And 6. I'm sorry, should have included 6 there.
If I may, Dan, forgive me. Again, in 6, I think you identified LTSS needs, right? So could you spell that? Oh, well, there it is, long-term services and supports. Okay, so I just, again, and I only point this out is there's a work group going over the 430 ORS 430 and looking at that. So just to be aware that we may be monkeying around with the statutes that particularly apply to local mental health authorities. And that's the only thing I just wanted to kind of flag.
Yes, thank you, Chris. And as I mentioned early in our conversation this morning, certainly we draft rules, we adopt rules, and then we often need to amend rules. And we make amendments based upon the experience of utilizing administrative rules and learning what may need to have some refinements. And also there are changes at both the state legislative level regarding laws, and there are changes at the federal level, and those changes can influence when we need to amend rules. As Chris identified, there may be changes coming to some of the state statutes, the Oregon Revised Statutes, or ORS. So we will have to take a look at those, as those may impact these rules over time. Okay. I think it's time for another stretch break. And we'll move on to the third rule. And while Edgar is pulling that up, I invite you to take a breath, take a stretch. Okay. Thank you. Thank you for hanging in there with me on this summer morning. I hope we're sort of mid-week, work week, and hope everyone is doing well. So this third rule, 410, 120, 1225, gets into the details about what it takes to really have that service coordination to support care coordination. to look at the right piece of paper here. Um, so again, these are standards for how healthcare should be coordinated. On page 1, invite RAC members to take a look at sections 1 through 3. These sections talk about how information should be shared with the OHP member and how our members need to be informed about the availability of care coordination services and how to contact their care coordination team or designated person. Chris, go ahead.
Yeah, and forgive me, I did not crosswalk the OARs, and I'm realizing I probably should have, but I made a note here. For particular populations, such as people living with serious mental illness, there is this enhanced care coordination that's called out by rule and in contract with the CCOs, for example. I didn't look if that applies to fee for service equally, but I would think that if that does apply to fee for service, would there merit some reference in here of the intensive care coordination piece that certain populations are eligible for by virtue of their diagnosis or condition?
Yeah, thank you for that question, Chris. I will need to go back and look. I was remembering that there were some changes to definitions and terms, and we'll certainly want to take a look at that for consistent terminology and definitions, because I'm not sure that, and I recognize that there may be requirements in contract for CCOs that might be different than how we have it for fee for service. So appreciate you calling that out. Okay, anyone else offering comments on sections 1 through 3? If not, we'll move on. So let's take a look at section 4, which covers part of page 1 and really all of page 2. Section 4 talks about developing a care profile. So again, a way to capture the needs of individuals so that it can be tailored to what that individual needs, and that information is communicated in a way that works for the individual, their preferred language, any language supports that they may need, along with their guardian or designated representative.
Chris in the chat just put a comment in saying the particular OAR I'm referencing, 410, 141, 3870, which I think has remained unchanged.
Okay, thank you for doing that, OAR research, Chris. Appreciate that. And again, we'll be saving all of the chats so that we have record of those and can make sure that we're considering everything that's been brought forward in both chat and in the recording verbally. So appreciate the conversation. Okay. Let's talk about section 5. That again continues on with the care plan. Again, it's referencing, considering individuals that may have little or low risk for needing care plan and care coordination. I want to call out that certainly individuals can request to have care coordination assistance. Against centering the voice of the individual. Thank you, Bonnie, for including the OARs that did go into effect earlier this year for Division 141 that had updated both the definitions as well as the 3 corresponding care coordination rules for CCOs. Okay, let's move on. Towards the bottom of page 3 is section 6. And this begins to take a look at the location of where an individual may be receiving care. So often individuals who may be transitioning from one care setting to a different one. So for example, acute care, hospital care to perhaps long-term care or a residential treatment facility, transitioning to a community-based care setting. Those are often those times when care coordination is critical to support the member during that change in care setting. Any comments from RAC members on section 6? Okay, I know we're into it here, so appreciate those who are staying with us. Let's go ahead and move to section 7, which is the last page of this draft rule. And again, calling out some of those populations with specific supports, the long-term services and supports, LTSS, or those individuals with special health care needs. It references the definition rule. And again, thinking about how care teams coordinate and develop an individual plan, sharing that plan with the member or their representative. Okay, quiet group as we get to the end. Okay, well, again, I recognize this is a lot of information. Again, I will send out the slide deck after our meeting, probably if not this afternoon, tomorrow, along with a short survey. But we're not quite done yet. Let's go back to the slide deck, Edgar. And while he does that, Chris?
Yeah, if it's now appropriate, I just had two general comments about the rules in general.
Please.
One applies probably both to fee-for-service and CCOs, which is a difficulty we encounter with this whole care coordination thing. And this is not, I don't have a ready solution here. I know this is a tough nut to crack, but particularly people with ongoing or complex behavioral health needs, that care coordination is assigned generally to whatever agency or provider they're assigned to at any given time. And it's often very fleeting in that if they change providers, they go to the hospital, something happens, suddenly all that shifts somewhere else where nobody really knows who they are and has to relearn their entire history. And so I just point out that the care coordination in general is, while it's very desirable as we're deploying it in Oregon, still hasn't reached its full potential. We have people whose needs are really slipping through the cracks because we just don't know where responsibility actually lies for the totality of someone's life as they encounter the Medicaid system. I think the other piece is just pointing out in the fee for service, and this is, I don't know, this is a rule issue, but it is probably a contracting issue for OHA, is that in the past, when they have done some or tried some attempts at this in our population, they usually are contracting with an entity that has no relationships anywhere across the state, and yet they're being asked to do intensive care coordination for a population that really needs it, for people who reside in multiple communities across the state. And so, while it's ideal for people to have it, how that's deployed, particularly in fee for service, will being cautious about making sure that people are actually getting care coordination, and the work is being done, and that the people doing it have the relationships to bring it about.
Thank you, Chris. Yeah, good points, all good points. And I will just say that OHA has a contract proposal, a request for proposals out that is specific to care coordination. And we're hoping to have those contracts executed in 2025. So more to come to build out that sort of the framework of this house that we're building, but appreciate that. All right, Edgar, if you could go to the next slide. I wanted to come back again to this vision and health equity definition, just to center the next few minutes of our conversation. Because again, as we work on developing rules and programs and policy, we really are striving to keep our health equity definition and in mind, and consider our vision of eliminating health inequities in Oregon by 2030. This is a strategic goal for the Oregon Health Authority, and we want to make sure that as we develop Oregon administrative rules and programs, that we keep that sort of as our North Star. So next slide, I will ask again, RAC members to offer some comments and feedback about the draft rules as we've been discussing today. How do these rules impact racial equity? Are there groups that, ethnic groups, racial groups, certain communities that could be potentially harmed by these rules or disproportionately impacted by these rules? So I'll pause with that question and invite any comments. Again, you can put those in the chat or ponder that over the next 10 days and send me feedback via email. And the third question here is, do these rules have any financial or fiscal impacts on the community? And think broadly about the community being members, partners, advocates, or providers. Okay. I hope I'm not alone in the room, but it looks like there's 28 people here. So again, welcome either written comments in the chat or emails in the future. So, okay. Yes, Dr. Hemmings, please.
Yes, you know, I'm thinking about fiscal impact on the community, and more specifically, providers who, I mean, how is this going to be funded? There's a cost to provide mean, to provide holistic care to our patients. And, you know, I'm just wondering how this would be funded, on a more micro level. So that's just something that, you know, when I see these expansions and services, I think it's great, it's awesome. But I'm also concerned about, and I see the CCOs, you know, being required to provide, you know, these services to their members. And I'm always concerned about how does those funds filter through to providers, in terms of making it financially feasible for them to have the appropriate staff, to meet the holistic needs of their patients. So that's just something that I'm thinking about.
Thank you, Dr. Hemmings. Appreciate that. Yes, we want to consider if there are some mechanisms that we could deploy. That's exactly kind of information we need to be considering. Okay, next slide, please. So just to kind of wrap things up, the next steps, really, as I mentioned, we had a Rules Advisory Committee meeting yesterday, this second one today. We got through all 3 rules. Thank you for plowing through that with me. We'll be taking back the comments and the verbal comments and the chat and written comments that can come to me by 5 p.m. on July 5th, and be looking at how we can continue to edit these draft rules during the month of July. There'll be a review internally, and likely with the input and review by the Oregon Department of Justice team, and perhaps an aggressive goal of having those filed with the Oregon Secretary of State's office by the end of July, which will include an announcement of a public comment period in August and a public hearing. Again, we'll be taking back those comments and making edits to rules that will require internal review and approval through our OHA leadership before we can file permanent rules with the Oregon Secretary of State's office, perhaps with an effective date by the end of September. I put an asterisk indicating that these dates are estimates and may adjust based upon external input like we're receiving today, as well as internal input and review. So thank you. Let's go to the last slide. I just want to recognize that this work takes all hands coming together. I extend my deep appreciation for your partnership, your engagement today, your conversations, and I look forward to continuing the conversation. I have my email there. Feel free to reach out to me and look for future updates around the rule development. I will stay on for a few minutes, and if anyone wants to have a conversation with a smaller audience, happy to do that. So hope you have a wonderful afternoon. Again, thank you.